So firstly, I want to say welcome to all the people here from Memphis. Say hello, everybody. Good morning. That sounds great. Thank you. All right. Today's supporters, we have Bristol Myers-Squibb, Genentech, Sandoz, and TG Therapeutics. We want to thank them for supporting us to do this program. We also have the exhibitors of Alexion, Biogen, Bristol Myers-Squibb, Genentech, Sandoz, TG Therapeutics, and Novartis. And these companies are here because they know the good that we're doing providing these programs in the rural and underserved communities around the United States, so they want to make sure that we're able to do these programs. Our speaker today is Dr. Jonathan Cockwood. He's a neurologist and fellowship-trained neuro-ophthalmologist with over 30 years of experience in clinical management of multiple sclerosis and neurological eye disorders. A true advocate for the comprehensive treatment approach, he crafts treatment plans to provide relief from MS symptoms while building long-term relationships with his patients. Let's welcome up Dr. Cockwood.
Well, again, thanks, Stuart, and kudos. Stuart and his team, they do an amazing job. Check out their YouTube channel. There are so many programs that they put up there. This one's going to get this one will get put up. Sorry, this one will get put up as well. But check out their YouTube. There's a ton of information. A lot of my friends and colleagues from the MS world have done programs with Stuart, and yes, he does stay on the road. We were comparing frequent flyer miles earlier today, and we both have a lot. So anyway, I'm the medical director at the Minnesota Center for MS, and I'm just going to share a little personal thing about Memphis. Memphis has been kind of important in my life. I started my first MS center in Louisiana in 2005, and it was a comprehensive care center, the first comprehensive care MS center that we'd ever had. And if you know what happened, we were open about 4 or 5 months, and then Hurricane Katrina wiped us out. So we remember that storm was going to the Panhandle first, so all the hotel rooms we usually evacuate to from New Orleans were full. So we actually wound up in Memphis. And I remember in a hotel, and it was the only closest place we could find that would take our dog and our kids and everyone else. The dog was the problem, not the kids. Maybe it should have been the other way around. But I remember a bunch of evacuees who were sitting there. It was 12:30. The storm had passed New Orleans, and we're breathing a sigh of relief, and we're all sitting in there watching the news. Some people had gone to bed going, okay, it looks like we get to go home tomorrow, maybe the next day, we'll see. And then the first reports of water in the streets in Lakeview were coming in on the news, and it's like, oh, wait a minute, Lakeview area, it's low, but the water should be going down, the pumps should be catching up. Then there was a report of water in the CBD. So personally for me, that was the first inkling of the levees failing in New Orleans. Now, the next thing, my next time in Memphis was shortly after that. It was about 2 months later, and we were displaced to Atlanta, our family, New Orleans was, you guys remember. So the next thing, I was actually here for a meeting that was planned, and I was speaking with one of my colleagues. He's now retired. He's an MS specialist from Miami, and we were in the bar after the meeting and sort of talking. I was telling him everything that happened, and that turned out to be rather pivotal of how I wound up in Minnesota. And believe me, my wife is 4th generation New Orleanian, so she was not happy about moving to Minnesota. But leading up to that, we didn't know what we were doing or where we were going to go, but it didn't look like we could go back to New Orleans anytime soon. But I was at this meeting with Howie, Dr. Zweibel, and then about a week later, the International MS meeting was going on in Greece, and I, of course, wasn't able to go, but Howie, who I was talking to, went to that meeting, and he talked to Dr. Shapiro, a colleague of mine, and Dr. Shapiro is the one who said, hey, in fact, he called me from Greece. I'm standing in a Kroger's at 10 o'clock in the morning. He calls me on the phone and says, hey, you want to come join me? And that's sort of how it all got started. So I got to say, Memphis is really, I have some, get a little triggered thinking about that time, when we first really saw what happened and what turned out to happen in New Orleans. But anyway, so long story, but I'm back, and different circumstances now. It's been a long time, and now the Minnesota Center for MS is up and going, and we recently moved. In fact, changed from the Shapiro Center now, and we're running the Minnesota Center for MS. And I'm really pleased to talk to you about a couple things I'm very passionate about. Visual disorders and MS, very, very important to me, and we'll get right to it. I'm going to talk a little bit about MS in general and just the disease itself. I think some of you are probably familiar with that, and then quickly get on to a few things. We're going to talk about one of the new emerging classes of drug right at the end that looks pretty exciting as well, an oral drug. So without further ado, let's talk a little about what MS is. And by the way, if you have any questions, like Stuart said, just write them down and we'll address them at the end. And although I have to catch a flight, which is why I'm going a little earlier, I will stick around. I'll be around for the questions after my session. So, all right, so what is MS? So MS is an autoimmune disease. It will only attack the central nervous system, which consists of the brain, spinal cord, and the optic nerves. And I'll show you a little bit about optic nerves here in a few minutes. So, and essentially, you couldn't get the optic nerve on the schematic, but I'll show you a couple pictures here. Here's kind of how nerves work. So messages travel up and down the nerves, and the peripheral nerve is what really is attacked by MS, and myelin is the insulation. So it's kind of analogous to the insulation on an electrical wire, although it's quite different. It's at least similar enough. So, and myelin basically is the insulation that allows efficient conduction of the nerve, and myelin is the initial target, at least, of what the immune system attacks in persons with MS. Now, this is a schematic of a very important cell. Let's see if my pointer, that little guy right there is called an oligodendrocyte, and his job is to make the myelin and that oligo actually nurture the nerve. They help the axon, this part of the nerve here, survive and function really well. They're very, very critical. Now, something important is these nerve cells, these oligodendrocytes, you can make more of these, you can grow more of these, but you can't grow new nerve cells. So if a nerve cell dies, it's dead and gone forever. But these oligocells, if they die or they're injured, you can potentially grow a few more of those. So some of our stem cell research has been focused a little bit on trying to, at least one target has been trying to get the oligodendrocytes to remyelinate. And we'll have some therapies, I hope, in the near future, but we're still a ways off from remyelination. I'll talk a little bit more about that later. But that's an important cell type. Now, this is kind of what the healthy intracellular environment should look like in your brain. So there's a nerve cell, the cell body of the nerve connects up to nerves locally, and then this long fiber that's myelinated with the myelin. And a normal healthy brain has no immune system activity in it. This is what the intracellular environment looks like in the brains of persons with MS. And as you can see here, damaged nerve cells. These cells' job are to go in and chew up and clear up the debris and the damage. The B cells are like the orchestra conductor. They're telling the T cells to attack. The macrophages can kill and eat up nerve cells. So, and all of these little tiny dot things here are the chemical messengers that are all driving this orchestrated inflammatory attack in the brains, optic nerves, and spinal cords of persons with MS. So that's messy, and this is what our treatments help to clear up. Now, so one thing we worry about, and I mentioned this before, this is an intact neuron. You have trouble seeing this in the back, but if it gets damaged, it can heal, but if it gets damaged to a certain point, then the nerve cell itself dies. And the oligocells, we can grow more, and they'll make myelin, but if there's no nerve there for them to myelinate, things don't work very well, right? So this is a really important thing to understand too. MS isn't just about demyelination or damaged nerve cells, it's about nerve cells that die. Now, what causes it? We don't know. Recently, we've had a big confirmation that a infection, a virus, the EpsteinBarr virus, some of you may have heard of this a couple of years ago. It was really very widely disseminated in the MS world was this research study that found a direct connection between mononucleosis infections, which is what's caused by the Epstein-Barr virus, and a direct correlation between that and persons developing MS. So we know that is at least a trigger, but just getting a mono doesn't cause MS, or 97% of us would have MS. 90% of people have antibodies in their blood to Epstein-Barr virus. So it doesn't cause symptomatic mononucleosis in most of us when we get infections. However, in people who go on to develop MS, they're much more likely to have symptoms when they do get exposed to the Epstein-Barr virus, and those symptoms are the disease mononucleosis. It tends to happen in teens, maybe childhood, somewhat in adults. So there's an environmental trigger in that case. It's a virus, a viral infection that triggers the response, but the individual has to be genetically susceptible. So that's why not everyone who gets Epstein-Barr or mononucleosis goes on to get MS, but people who are susceptible, that is at least one of the triggers. And then what happens is autoimmunity. Now what autoimmunity is everybody's immune system makes mistakes, but our immune systems are very resilient. Our immune system fixes those mistakes. So the problem when someone develops an autoimmune disease where the immune system attacks self instead of something foreign, which is what it's supposed to do, if it makes that mistake, those mistakes get corrected. So the big problem in MS is not that the immune system is overactive or underactive. It's just poorly regulated. And when the mistake is made, the mistake actually gets propagated, so the immune system will attack more and more nerve cells and other parts of your central nervous system. And an endpoint of that attack is loss of myelin and those nerve fibers that die. And in the individual, it causes symptoms. I'm going to focus mostly on the symptoms relating to vision, but obviously MS impacts all parts of the central nervous system, causes lots of problems besides vision. Now, here is an indication of that damaged nerve cell. This nerve cell is dead already. Once it transects like that, it's just going to slowly dissolve and slowly go away. What we've learned from our research on MS, time equals brain. Even if your disease appears to be well controlled, this is a disease where we really have to get out ahead of it because it's silently killing off brain cells. Even when people appear to be, they're not making new lesions on their MRI scan, they may not be making relapses, but they're still losing brain cells 2, 3, maybe 5 times the rates of aging. So it's very important that people get on treatment and stay on treatment, and that we escalate that treatment to stronger treatments if it's not effective. So monitoring, various ways we can monitor. I'll talk a little bit about a way we can use the visual system to monitor MS when we talk about vision in a minute. So this is what we'd like the nervous system of people with MS to look like. And again, we'll talk about a couple of ways we get there later. So we'll shift gears a little bit and focus really in on one set of issues with MS. Now, I started out not as an MS specialist. I started out as a neurologist trained as a neuro-ophthalmologist. And so in New Orleans, I had the largest neuro-ophthalmology practice in the Gulf South, and I would see these patients come with optic neuritis, common problem, double vision, brainstem syndromes. All of these things affect vision. MS commonly picks on the optic nerve in the base of the brain. The base of the brain or the brainstem's involved in, besides balance, coordination, control, eye movements. And I'm going to give you a little framework of how to think about this here. But so optic neuritis in this example, this is an MRI slice, and we see, you can't see it from the back, but there's a little inflammation in the optic nerve right there. So that's what your doctor's looking for when they do an MRI if you have optic neuritis, to see if there's inflammation in that nerve. Typically after optic neuritis, the visual recovery vision tends to worsen for 2 to 4 weeks, and then the vision will start gradually recovering. Within about a couple of weeks, it's usually improving. typically at the 3-month point, we'll see most people, more than 90% of people have recovered to 20/40 vision, 20/20 being normal. 20/40, you can actually drive a car, maybe a limited license with 20/40 vision. But eventually, the vision may improve or recover almost completely in some people. But by 3 months, it's near fully recovered. Roughly, it's going to happen again within about 10 years in the other eye. It may not be, it may be subtle, and as we find more and more over the lifetime of someone with MS, approximately 90% of people are going to have some kind of damage in their optic nerves. Now, what this tells us is we can use the optic nerve to gauge MS. Optic neuritis itself does not necessarily mean you're going to have a bad outcome from your MS. Relapses that affect sensation and you recover really well from them. Relapses that affect vision and sensory things with good recovery don't have the same implications for the severity of your MS that other relapses, like something that affects your strength or your bladder or your balance and coordination. Those types of relapses we know as MS experts, and many neurologists know this as well, that those types of relapses put the individual at a greater risk for developing disability in the future, and we need to be very aggressive with their preventative disease-modifying therapies in those situations. So having optic neuritis by itself is not necessarily bad. However, if you have a very severe case of optic neuritis and you don't have good recovery, or if it affects both eyes at the same time, there's another disease that mimics MS. And while there is a blood test for it, the blood test sometimes misses it, a disease called neuromyelitis optica, and it doesn't respond to the same treatments that MS does. So it's often important to distinguish this when we have someone with optic neuritis you suspect has MS. It might be another disease. So in most cases, the repair that occurs is incomplete, while the vision may seem normal, if we measure it really sensitively, we can often tell that 100% recovery doesn't occur. So we know that if we give people steroids, that it will speed up the recovery. Now, I imagine many of you with MS in this room have probably had steroids. I think it's important to understand what we can expect for steroids. When I talk to my patients about this, I describe kind of 3 buckets of treatment: disease-modifying therapies, like I'm going to talk to you about a biosimilar drug coming available later that's a disease-modifying therapy, and some of the emerging treatments. These are preventative. They are to stop MS from causing damage. Then, disease-modifying therapies, and we have symptom-managed treatments, and then we have treatments that we use to speed up the recovery when someone does have an attack, and that's the bucket that steroids are in. So whether or not you get steroids makes no difference into how much you're ultimately going to recover from the attack. It just speeds up the recovery. In a similar way, that's true with optic neuritis. We also know that if you're on a disease-modifying therapy, that you're not only are you less likely to get optic neuritis as well as any other MS attacks, that optic neuritis tends to be less severe. So that's another important reason to get on an MS treatment, disease-modifying treatment in this bucket, and stay on it. And if it's not working or not working well enough, escalate to a stronger treatment. Okay, so there's a few things that might be left over. So there's a few things we have to think about. Usually the visual acuity, reading the eye chart, how far down you read the eye chart is what we call Snellen visual acuity. There's another problem. I'll show you an example of this later, something called contrast sensitivity. So contrast sensitivity, it's the ability to distinguish subtle shades of gray. Try saying that 3 times fast. Subtle shades, distinguish subtle shades of gray. Most people notice contrast problems on dusk and dawn conditions, gray, overcast days, and where I live, if it's a gray, overcast day and there's a lot of snow around, it's Minnesota, right? So there's a lot of snow around, about half the year it seems. Contrast is really hard to pick out these subtle differences in these shades of gray. It's not a type of vision loss that people can kind of say what's going on. They just come in and say, there's something not quite right. In certain lighting conditions, I just don't see well. And there might be some things we can do for that. And I'll talk about that in a minute. There's a specialized eye chart. That's one of them, low contrast letter acuity chart it's called. Some regular ophthalmologists have charts like this. We do in the MS Center, and we measure people's contrast vision regularly because we also know we can track contrast, and if someone's contrast is worsening, it means their MS isn't under good control. Now, there can be other reasons, but if it's worsening due to MS, then that correlates with poor control of the disease, and we might need to think about increasing you to a stronger treatment. So the more times your optic nerve is damaged by optic neuritis, the less likely you are to recover fully. Later on in MS, after someone's had the disease 10, 15 years or so, their optic nerves may just be very slowly worsening, even though they're not noticing any new symptoms. It's just happening very, very gradually over time. So that also means we can use the optic nerve to tell us things about the disease. Now, tried to give you, it's kind of hard to explain what having had optic neuritis in one eye is like. So one of the things people notice besides contrast is color differences. And bright reds and bright greens are the colors that typically your eye doctor is going to use to kind of gauge that. But this is an attempt to kind of say, bright red sports car out of left eye and the right eye had optic neuritis. Things aren't quite as clear, but the red color is a bit faded. So it's the brightness and intensity of the red that changes after having optic neuritis. And sometimes we'll even use that in someone we suspect might have MS, and maybe they've never had optic neuritis that they know of, but we catch that there's a difference in the red saturation between their two eyes. And I can look carefully at their optic nerve and sometimes see color differences in the optic nerve in someone who never realizes they had a problem in that eye. So it can be useful for lots of things, but this might be the experience of someone who's had optic neuritis if they had incomplete recovery. And at a minimum, they might just have some contrast problems. So I want to talk about another thing that MS does is impacts the brainstem. Now, the brainstem was what I was talking about, the base of the brain. The brainstem is involved in control of eye movements. When you're reading up close, your eyes have to bend in so you can focus at something up close. So convergence problems, reading problems, double vision, might have some eye strain. And then if the brainstem's damaged, modulating those eye movements. So people might have nystagmus, that's a jerking movement of the eye. Might be nystagmus when they're trying to focus on something and things feel like they're wiggling and jiggling around. Sometimes it's when they look to one side, you can actually see the eye moving in people's visual experiences. Like things are disrupted and moving. Sometimes they'll even have a little double vision. If another part of the brainstem is damaged, the eyes won't align properly. So I describe it as Marty Feldman eyes. Remember the British comedian? He died a few years back. He actually had Graves' disease, but his entire career was based on these bulging eyeballs, and one eye looked over here and one eye looked over there, and he looked kind of crazy, and he was a comedian, so it kind of worked for him. It worked for his career, at least. But if you have one eye looking at this image and one eye looking at this image, your brain's confused, and you see double. Your brain sees two images. So, and that comes primarily from the brainstem. Oscillopsia, I just like that term. That's the sensation that the individual has when their whole world is jiggling and oscillating. It's called oscillopsia. That's a medical term for it. I just like the term, put it in there. So anyway, brainstem is another area, and about half of people with their first event of MS is going to be some injury to the brainstem or some problem coming from the brainstem. Up to a third of people may have their first event cluing us in that they have MS is going to be something that happens to their optic nerve, like optic neuritis. So these are very common presenting problems that help us diagnose people, and as well it's something that people with MS may have to live with because damage in this part of the brain sometimes leads to permanent symptoms that don't go away, or they improve but they don't resolve completely. Now, I wanted to mention this technique because this is a technique that is available in most ophthalmology offices now, and in a few MS centers where we're doing this regularly. what this image is here is, this is an image of the back of a person's eye, and there are these layers of nerve. Well, the top layer is nerve cells. So this is the retina, and in the back of your eye, in your retina, this is the inside of the eyeball. So light would come this direction into the retina. And a little schematic, if we blow this up to see, right along the top is a nerve layer. This is the part of the back of the eye, your optic nerve's right there, very center part of your eye. So that little divot right there is your most important vision. It's called the macula or the fovea. That's what we use for acuity, detail, things like that. Whereas further out in the periphery, it's more like your peripheral vision where you detect movement and things like that. So now, very, very important, because we can measure the thickness of this nerve cell layer, and that can tell us about how MS is damaging your brain. So that's what the layer looks like on this optical coherence tomography test. It's a very, very sensitive test that we're using to track people's response to treatment. It helps us diagnose them. It is a biomarker of disease activity. So here's an example, and I wish I could show the video clip of this, but this is something called, this is the doctor talk for it, intranuclear ophthalmoplegia. We usually just abbreviate it. We'll say INOs. So if your doctor is saying something like INO, that's what it represents, intranuclear ophthalmoplegia. Now, this is a damage at the base of the brain. And it's a very common structure at the base of the brain that is really close to, well, it's just an area that's commonly picked on by MS. And in this gentleman, these are gaze photos. So in this middle set, he is looking straight ahead, and his eyes are pretty well aligned. When he looks to the right side over here, they line up pretty well. When he looks to the left eye goes fine, but the right eye doesn't move. Now, if this were in real time, you would see this eye making kind of jerking movements as he tries to look in that direction, and this eye just not moving. Now, sometimes this eye will move a little bit, but just not normally, or sometimes it'll just lag. Now, the experience that the patient has with this is they may not have double vision when they're looking straight ahead, when they look to one side. If it's this gentleman, when he looks to the left side, he's going to have a lot of double vision. If someone has a mild problem with an INO, when they look to the left side, the right eye just might lag a little bit. So the experience of the individual would be, when you look to one side or the other, you might briefly have a little double vision, or that phrase I like, that word I like, oscillopsia, kind of sensation of your vision jiggling or moving around just for a second or two, and then your eyes will line up okay. So it can have very subtle symptoms, or it can be kind of major where you're having a lot of double vision and it's really impairing your day-to-day functioning. There can be other problems of damage in the brainstem. It can affect balance. It can affect weakness or cause weakness in your face. It can cause slurred speech. So these are just some of the things to think about with this damage in the brainstem. But intranuclear ophthalmoplegia, when you see a neurologist, when young people have this, it almost always turns out to be MS. Older people, kind of people my age and older, sometimes we see strokes in the brainstem, might be vascular disease, but this is a very common problem we see in MS, and when we do see it in someone as the first event, if it's somebody younger, it almost always turns out to be multiple sclerosis. All right, I mentioned contrast and contrast sensitivity to you before. So this is another biomarker, a way we can measure how the disease is changing over time. Are we responding to treatment? We use OCT to diagnose people as well as to track the disease as a biomarker of the disease itself. So this top eye chart would be more typical of the type of eye chart you might read if you went to your ophthalmologist office. A black letter on a white background. Now, the one you're used to seeing is called a Snellen chart, where it's not V-shaped like this. This chart is actually a chart we use in research, vision testing for ophthalmology research. But this one is something called a Sloan low contrast acuity. Now, you can see how much dimmer the letters are here. The actual chart we test you with is the letters are so dim on that chart that it wouldn't project on this slide. It's really, really difficult to see. So first we test you on this chart and see how far down you read. And we know what roughly, if you read down to about this level, that would be the equivalent of about 20/20 vision. And then most people who could read this level are only going to read maybe this level. But if they've had optic neuritis, sometimes they're only able to see a few letters on a chart like this. So this correlates with that contrast loss. So when people have a very subtle problem with their vision, kind of coming and describing, saying, it's dusk and dawn, I can't see very well, or flat lighting conditions, this is often what's gone on. Even if they never had optic neuritis, we measure their contrast, and many people with MS have impaired contrast. Now, not just MS causes contrast vision problems. Cataracts can do it, corneal problems, other things can do it as well. There's actually even some research showing that it can come from the occipital lobe in the brain, but in most people with MS, it's coming from damage in the optic nerve. Now, we can use this tool to measure how people change over time. It's an inexpensive, quick test to do. Takes about 5-10 minutes or so. We found this bullet point here, 77% of people that we test with clinically definite multiple sclerosis have some problem with their contrast. And again, we've used this tool in research, and I use this clinically. I track this in my patients. We check this every 6 months to a year. As well as I measure the brain cell densities out of the back of their eyes with the OCT test, and we do this a couple times, usually twice to once a year. And we know that if you read down here last time and then 6 months later you read you can't read, if the change is 7 letters or more, something significant happened in your optic nerve. So it's a very sensitive measure for change in MS, and something we can use along with other measures, MRIs, your neurologic examinations, tracking your symptoms to decide, and symptoms and relapses, to decide if your treatment is working well enough. If you have contrast sensitivity problems, we can't fix the optic nerve yet. Some of these remyelination therapies we're thinking about, in fact, some of them have been studied in optic neuritis in MS patients, and we can actually show that we can remyelinate the optic nerve, but it hasn't made enough difference so that people's symptoms improve or their vision gets better. So we're working on those things. But there's a few things we can do to maybe treat some of these visual symptoms. So if you have contrast problems, tinted glasses, a yellow tint, people with MS, if you have sunglasses, make sure that you don't have like those photo gray in your regular glasses, or if you get sunglasses, get an amber tint, a reddish or yellowish tint, and that will actually improve your contrast a little bit. If you get sunglasses that have a gray tint, it actually will make your contrast vision a little bit worse. That's fine for that. In fact, I even have in Minnesota, I tell my patients, keep a pair of ski goggles in your glove box, or I'll have them keep a pair of shooter's glasses. Sportsmen's, motorcyclists wear them too. Very light yellow tinted glasses, and just keep it. Keep it in your glove box in case you ever get caught in flat lighting conditions. You look kind of funny if you put on one of those ski goggle things, but you could use regular glasses or whatever. But that light yellow tint will improve your contrast. So we can't fix the optic nerve, but we can do things to make your contrast vision better. Now, double vision is tougher. Double vision, you can put prism in the glasses. We could tape part of the lens, the person who looks to that side and has a bunch of double vision for a second or two, if we just tape that off a little bit, tape in the glasses, that'll make their symptoms better. They won't have the oscillopsia. It doesn't fix the problem. It just improves people's symptoms. So, and then a few other things. There are actually some of the medications we try to treat nystagmus. There's an Alzheimer medication. It's not the new one you've heard about recently. It's one of the old oral tablets, and a couple other things that we might try. And ultimately, if there's a whole lot of vision loss, there's not too much more we can do about it. We might have you see an occupational therapist who specializes in low vision. So here would be an example of maybe some very light yellow tint in some glasses. There are various things of loops and magnifiers. This is an old slide. That was high tech at the time. Now there are all these magnification. I have a magnification device right here. You can put your camera on and enlarge something to see it. Various things we can use now. So, but often you'll work with a low vision specialist, a dedicated professional who can help you function better with the damage in your optic nerves that you have. Now, another thing I'm passionate about, in part because, so shifting gears, we're going to talk about access to care. Comprehensive care in MS, I'm very passionate about this. The very first MS center I started in New Orleans, the one that didn't do so well in Hurricane Katrina, was a comprehensive care center for persons with MS. Most people with MS never are ever seen in a comprehensive center. Comprehensive care looks a little different. The typical model of care, a neurologist in an office, kind of like a primary care doctor. You go in to see the neurologist, they look at your MRIs, they tap on your reflexes, scratch the heck out of the bottom of your foot for some reason, right? Make you do a few silly things, and somehow we figure out something about you and your MS from that. Well, that's kind of what a clinic neurologist does. They might treat a few of your symptoms or things. Comprehensive care is different, and this evolved out of the needs of persons with MS. People with MS have a broad plethora of needs. When I was a neurologist working in a clinic model of care, I was frustrated all the time. I was at the Ochsner Clinic in New Orleans, and I kept going to administration saying, look, I can't treat my patients this way. They have more needs. Isn't there some way we can integrate care? Can we develop an MS center? And then I went to my first consortium of MS centers meetings to realize there really are comprehensive care centers all over the country. Now, comprehensive care looks a little different than the doctor sitting behind a desk, the neurologist sitting behind a desk in an office. It's a team of people. There's usually an MS nurse, often medical assistants, nurse practitioners. In our center, we have a coordinated care team where my nurse practitioners have roles. They're managing people's symptoms and quality of life issues. That's another really important focus of a comprehensive care center. We focus on how you're doing in your day-to-day. We try to educate people about the disease, about things that they can do to help themselves and to improve, and just improve their day-to-day ride. We may focus on things like psychosocial support, treating their sensory, their motor, if they've got cognitive problems, evaluating those things and tracking people really carefully, measuring those things that are biomarkers of the disease that can help us identify treatment failure. Remember, time equals brain, right? If you're on the wrong treatment or it's not effective enough, you're losing brain cells that we could otherwise have prevented. So I think a comprehensive care center, we're just better able to monitor people more carefully. I couldn't do it by myself. When I was a clinic neurologist, I couldn't do that, but I have a team to help me. So the MS specialist, we're really able in this setting to address a broad range of issues, and people's experience is better. Over and over again, we've seen this in surveys of patient experience. So this team, again, might be in a single facility. It might they look really quite different all over the country, but they've evolved to meet the needs of the specialists caring for people with MS and the people with MS. So that team might include the knowledgeable individual with MS, also known as the patient. I emphasize the word knowledgeable because one of our goals in a comprehensive care center is to educate you about the disease, but especially about those things that you can do to make your disease better, to make your quality of life better, or even prevent your MS from getting worse. Something as simple as vitamin D has an impact on slowing down the disease. Regular cardiovascular exercise, managing your other medical problems. If you have diabetes, hypertension, obesity, a huge problem. People who are obese with MS, and this isn't just MS, other diseases too, but particularly in MS, if you're overweight, your immune system is more aggressive in attacking your brain and your spinal cord. So losing weight, diet, something like a Mediterranean diet. I should have checked to see what was on the menu today. Yeah, it looks okay. Chicken's good. Yeah, all right. So no big old steak on your plate. That would be like not a good diet for MS, although who doesn't love a steak? So those are some of the things that we have to keep in mind. So friends and family are part of the team. Care partners, support partners. The MS specialist isn't at the center of this team. You are. You're at the center of this paradigm. Your support partner is at the center of this paradigm. We're peripheral to that. We help you. Maybe there's resources in the community, other providers, nurses, social workers, psychologists, physical therapists, occupational speech therapists. It takes a village, right, to raise a child. I had 2 kids. I believe it. Takes a village to care for someone with MS. To really provide the care that someone with MS needs, it takes a village. So what does that village look like? Well, MS patient, you're at the center of the paradigm. MS specialist might be a very important part of that paradigm. There might be other providers, PCPs, internists, urologists, gynecologists, orthopedic doctor, ophthalmologist, physiatrist, that's physical medicine, rehab doctors. A nurse, a social worker, PT, OT, speech and language. This one I like, recreational therapist. I don't have one of those yet. I want one. I want one for me. Psychologist and neuropsychologist. So these are all really important people that are all part of the team that is needed to care for people with MS. So, person with MS is at the center of this paradigm. There are patient-related considerations. We have community resource and then the MS health team, but the person with MS is right there. And all of these other like National MS Society, Stewart, and what Stewart does in educating people and taking this compass to care on the road, as well as all the other programs that he and his team at MS Views and News do. Would be an example of community resources, advocacy. So all of these things are important, vitally important. Now, part of our approach to selecting a disease-modifying therapy, and I don't necessarily mean to tie this, there are plenty of doctors not in comprehensive care centers, neurologists, who will use this shared decision-making approach, but in general, you're going to see this much more commonly in comprehensive care centers. We look at all of the factors, the treatment-related considerations here, the benefits, risk-benefit of the treatment, the mechanism of action of that particular treatment, how it might impact the immune system, our real-world experience that we have, how the experience of that, the cost to the individual. Does your insurance cover it? Can we get this treatment? Are there generics or biosimilar available if you can't get a trade name drug? So these are all would be things that a comprehensive care center is going to focus on a little bit more in the process of selecting a treatment. There may be factors on the MRI scan or something about the neurologic exam that suggests that you're at greater risk. Like I mentioned before, if people who have optic neuritis or sensory relapses they recover well from, we don't worry about them quite as much, although we still want them on effective treatments. But if we identify risk factors that someone's at risk of developing even greater disability in the future, then we refocus on this. So this is all part of that, and then the patient gets to decide lifestyle, education, family planning, their work, quality of life, are they going to have kids? All of these factors come in. So that's kind of what I think I would really love to see everyone have access to this comprehensive care model. And although it's available, I really don't think too many people with MS ever get to experience this. It turns out in our studies about a third of people with MS will ever be seen in a comprehensive care center. So the vast majority of people, their care is delivered with kind of a clinic model of care, and they don't get to benefit from this type of paradigm. Just another topic here. Briefly, we're going to talk about some evolving trends here in some of our treatment options we'll have pretty soon. So small molecules and biologics, I think we have to kind of understand generic drugs tend to be small molecules. We can kind of measure those molecules in a lab on a bench and really tell pretty much, assay them and pretty much tell how they're going to work. Biological drugs are a little more complicated. And when a biological drug goes generic, we tend to call it a biosimilar. So that's just a little difference in the technology there. So I took some of this, sorry about all the fine print, I took some of this straight from the FDA's website about biosimilars. So there are approved biologics. They go through this really extensive regulatory evaluation and approval process. The reference medicine is the original drug rather than the biosimilar. And I think what I'm going to talk to you about is natalizumab. Tysabri is going biosimilar here pretty soon. So that would be an example of a product that's gone through this process. So confirmatory clinical studies are assessed, and then a biosimilar is then approved based on these evaluations and how well it compares to its reference product. So I think, oh gosh, this slide bores me. It doesn't add too much more. I'm going to skip over this one. It's a government website, right? So if you ever need if you can't get to sleep, go on the FDA's website. It'll put you to sleep real quick. So and again, I think all of these essentially biological drugs and a recent act paving the way to streamline the approval process, because part of access to care is access to the medications. And if you can't get access to the medications, maybe you can see the neurologist, but if you can't afford the medicine or you can't afford the copays for the medication, doesn't do you any good, does it? So that's part of access. So I think in the broad strokes, biosimilar drugs will drive and help improve access to care by reducing costs. And essentially, I'm summarizing over a lot of these slides. But there is basically, I wanted to show you this. So this is a systematic review of over 90 studies on switching when someone was switched from the reference drug to a biosimilar product. And what we see from this, and actually this is kind of an old study, there's even more data on this now, but in general, the majority of these comparative studies did not report any significant differences in the immune system impact, the safety, or the effectiveness of those treatments. So again, giving us confidence of the biosimilars that when a biosimilar comes out, the FDA has studied it in depth and compared it to the reference drug. Now, briefly, emerging drugs. We're really excited about, I think, the next wave of a new class of drug. Now, let me explain that. Class of treatment is drugs that work in a similar way. So like the interferon drugs, Avonex, Betaseron, Rebif, those injectable drugs. They work in the same way. There's several examples in MS of similar drugs that have a similar mechanism of action. The BTK inhibitors, I think, is a brand new class for us. It works in a completely new way. So we have a brand new way to impact the immune systems of persons with MS that has been proven, at least at the phase 2 level, to be effective. And it works on an aspect so-called the innate immune system that none of our MS drugs have ever impacted before. The preliminary research is exciting. We still don't know very much yet. These drugs act inside the brain and as well as outside the brain, and they work on enzyme systems. We've never had drugs like this before. Over the next 3 to 5 years, we're going to be getting a few of them. I'm going to just briefly show you a couple of studies. This is one of them. This is kind of, we're just kind of figuring out different dosages. So this was a dosage ranging study. They just tried different dosages of the medications. Another study, a different drug, it's showing its effect on relapses. Now, these are phase 2 studies, so we will very soon, and this is another drug, so I'm not going to go through these exhaustively. This one's in a study going head-to-head against primary progressive MS. So we have these drugs, stay tuned. These are called BTK inhibitors. Burton's tyrosine kinase is what that stands for, and it's a whole new deal, and it's a whole new thing. Now, this is just the press release. It's old, but this was the announcement that we now have the drug Tysabri is going into is now biosimilar. So stay tuned. That's going to be rolling in probably later this year when a biosimilar drug for MS will be available. And we've been looking forward to this, and we're quite excited about that. The more tools in the belt we have, the better.
Great. Thank you very much.
Sure.
Everybody give
Take
a round of
questions now.
applause. Thank you. If we do have a person that did hand in one, and it's written as, if my grandson or my daughter or son or whatever has a lazy left eye, would that indicate MS?
Yeah, so lazy eye, the medical term for that is called amblyopia. So we're all snowflakes, basically. We're all just a little different. And some of us, when we're born, those pathways in our brain to yoke the eye booms together aren't really tight. And a lazy eye, so first of all, answer the question, no. A lazy eye does not mean MS. It might, a double vision might, but a lazy eye is when the brain, when the brain isn't aligning the eye, driving the eyes to alignment. Typically, what we do for a lazy eye in childhood now, and actually we used to be not as aggressive with doing surgery and things, but what we typically do is we patch, alternate patches, and we make the child use both eyes. The problem is if you let that lazy eye just laze around up until about the age of 8, 9 years old, beyond that, it may become permanent, or rather, the brain will begin to ignore the vision out of that eye, and then that eye's never going to be all that useful to the individual, or there'll always be diminished vision in that eye. So it's really important in a child to do that patching, and if the patching doesn't work, then they do surgery to realign the eyes, and they're much more aggressive. If you're born with the lazy eye, or it's noticed in development in early childhood, it is not an indication of MS. And usually your eye doctor is going to be able to tell the difference. You wouldn't necessarily need to take somebody to a neurologist to know that. So the first place to start would be with your ophthalmologist if there's any concern. Another question?
You were saying something pertaining to EpsteinBarr virus.
Uh-huh.
What is the connection between Epstein-Barr and MS?
Yeah. So, we've been looking at this for decades. And there's a study going way back where we looked at military recruits. When you go in the military, they draw your blood, they freeze and hold it. So we have a sample of their DNA, we have a sample of their serum, we have a sample of proteins and chemical messengers that are just suspended in time. Several studies have looked at this, and one a long time ago that first really piqued our interest here was they looked at these military recruits and they said, well, let's go look at people who developed MS and go back and look at their blood before they developed MS. And what did they find? Lo and behold, they found that something like, I'm going to mess up the numbers, 97.9% of people had antibodies in their blood against Epstein-Barr virus, the virus that causes mono. And they said, we found the smoking gun, right? If 97+% of people have this antibody in their blood who have MS, well, then they looked at the rest of the blood samples, and it turns out like 95% of everyone else has Epstein-Barr virus antibodies too. So we're all impacted by Epstein-Barr. Now, then what happened, so that piqued a lot of interest and a whole lot of research in this particular virus. Now, Epstein-Barr is a DNA virus, so what's interesting about a DNA virus is it puts a little bit of its DNA in your body when you're infected by it. So it's almost like it leaves a little back door behind. So a recent study was able to go into much more detail on some of these military recruits and get very granular down to when they had Epstein-Barr, did they have symptoms? Did they have symptomatic mononucleosis infections? And they found a very high correlation with that. And in fact, the more symptomatic somebody was from their mono infection, the more likely they were to get MS, and the more likely that MS was to be severe. So there seems to be this direct correlation. So we don't fully understand this yet, but it seems like Epstein-Barr virus triggers MS, but only in people who are genetically susceptible, and we haven't quite figured that out yet. But stay tuned. We know a lot about genetics. We're learning more and more about the human genome as it relates to MS all the time. So I think in the next few years, you're going to find some interesting things. One of the practical impact of this discovery is we're working on vaccinations against Epstein-Barr virus. Now, are we going to vaccinate the whole world against Epstein-Barr virus? Probably not. But we know that if you have MS and you have children, a male child has a 2% chance of developing MS, a female child has a 4% chance of developing MS, roughly 10 times the rate of the general population. So I think one practical impact of this research is if we can vaccinate, especially when they're younger, we're not exactly sure when this MS really starts in people, but vaccinate them at a young age against Epstein-Barr virus, we may very well be able to prevent MS before it ever gets started. That would be ideal. If we can genetically identify the genome or the pattern of different genes that leads to MS, those are people we can vaccinate against Epstein-Barr virus as well.
Person is asking if it's worth it to take Tysabri.
Well, first of all, I can't really answer a treatment question for an individual who's not my patient.
In general, is it worth it to take Tysabri?
In general, always that disclaimer though. Tysabri and the soon natalizumab biosimilar are highly efficacious drugs. So in general, when we look at a drug like Tysabri, I think one of the things that we have to focus on is the risk. There are ways to assess somebody's risk. Primary risk, or at least most worrisome risk with Tysabri, is a brain infection called PML. It's caused by a virus called JC virus, and that virus can be measured in a simple blood test. So that would be important. And in general, it would be important on a drug like Tysabri to make sure you're being appropriately monitored for it. Another really important thing about Tysabri is something called rebound disease. You have to be really careful. If you ever stop Tysabri, you have to do it under the supervision of your neurologist. It's very, very important because it could really cause you a lot of problems if you abruptly stop it and your neurologist doesn't know it. So two very key things.
Can you tell them why? Tell them why it becomes serious.
Well, in terms of rebound disease could actually put you in a wheelchair. It's multiple relapses. It's very hard to get it stopped. There's about 6 months to a year of one attack after another, nasty lesions on the MRI scan. So very, very cautious, very, very important that you do not abruptly discontinue Tysabri without the knowledge of your neurologist. And your neurologist should take steps. There are some things we can do, transition you to another medication for a while, and we need to do that within about 2 to 3 months of stopping the Tysabri, or you could get into a lot of trouble neurologically and a lot of disability.
I was trying to see, I have primary progressive MS, and I know it's not a lot of DMTs for primary progressive. I was on Ocrevus, but I didn't do well on it, so my neurologist, my neurologist decided to stop, doing it. So right now I'm not on anything. And I saw him last week, and he said something about switching to Tysabri and stuff. And now just listening to you, and then I'm not even sure I even want to do that. Is there anything? I know primary progressive MS, there's not a lot. So is there anything else, that you would say, that you would give your patients if they couldn't do Ocrevus? I'm going to say that.
Yeah, so right now there isn't. So for primary progressive MS, if you did not do well, and again, I can't give you specific recommendations, but if you have primary progressive MS, Ocrevus is the only drug that has ever been proven to be effective. Tysabri does not work for primary progressive MS. So if that is the type of MS my patient has, we don't even discuss Tysabri as an option. Now, Ocrevus is the only drug proven in a research study. There's a very similar drug to Ocrevus, depending on whatever problems you were having on Ocrevus. There's a similar drug that's not FDA approved for that use, works in the same way, might actually have, depending on what your problems were, it might actually have the same problem, but that's often a drug that I might use if there were a specific issue with Ocrevus. I might use this other drug that is the identical molecule to Ocrevus. There is a head-to-head study ongoing now, but we don't have data yet. So stay tuned. We're expecting data sometime next year, and that'll be our first sense. If that data is positive, it's going to be probably at least a year. So I think maybe 2025 we might see a new treatment for primary progressive MS.
Hi.
Thanks for trying.
Thank you. All right, next from online. From online, there are several, so give me a moment. Does the EBV reactivate during relapse? Why don't doctors do blood work and check it during relapse? Is the vaccine going to be made for it?
So I kind of already addressed the vaccine issue. Probably you'd already written your question by then, but the vaccine. So yes, there are vaccines under development. You have to look at EBV as a trigger of MS. It's not an ongoing marker. It is not a biomarker of disease activity. It might be something we measure, and honestly, just checking your Epstein-Barr virus levels probably don't help us very much since it's not that specific. Someday we may use that to help diagnose the disease, but it won't change in a relapse. It's not the Epstein-Barr virus that is attacking the nervous system. The Epstein-Barr virus triggers the immune system, and we're not exactly how, but it triggers the immune system to cause MS, or at least in genetically susceptible individuals. So we don't use the Epstein-Barr virus blood level to track things like relapses or track how you're responding to treatment.
Thank you. Next, what happens with the older drugs, once known to be a great medication? Where are they now, and why are they never discussed anymore? Do we give up on old cars?
I like the question. No, we don't give up on old cars. I have an old car too, but we spend a lot of time fixing them. They spew a lot more stuff into the atmosphere, and they're likely to break down, and they just don't work as well as new cars, even though I love my old car. But it takes a lot more effort. And that's almost kind of the what we can say with MS drugs. Great analogy. I might use that one in the future. So we'll just lump those into the legacy drugs. So the main issue, I think, with the older drugs, the injectable therapies, the first drug we ever had, Betaseron, quickly followed by Avonex, then Copaxone, then Rebif, in that order here in the U.S. So those are drugs that are still around, and they're still being used. They're not initiated as much very often. They're a little harder to take. Now you can say, gosh, do you want to do a shot 3 times a week, or would you like to go get an IV once a month or an IV every 6 months? So there's some convenience and tolerability issues. But for me, my concern is, in general, those drugs just aren't as effective as our newer, highly efficacious treatments, the monoclonal antibody class. And we're hopeful that this BTK class will be good too. Excuse me.
Okay, so I take Ocrevus. I've been taking it now for about 4 years. I was told that it's one of the strongest medicines if you have lesions on both your brain and spine. But does your body get used to the Ocrevus? Because it's seeming that my symptoms are progressing maybe, but according to the MRIs, I have no additional lesions. So could my body just be getting used to the Ocrevus, or how does that go?
So no, if Ocrevus doesn't stop working, probably none of our MS drugs stop working. but the disease of MS changes. Early on in MS, the disease is very inflammatory. Inflammation shows up on MRI very well. Later on in MS, we see, maybe it's still inflammatory, but it doesn't show up on MRI very well, so we don't tend to see new lesions. And then people may just have slowly worsening symptoms. And that might correlate with more brain atrophy, their brain shrinking faster than aging, even though we're not seeing new lesions. Brain atrophy is hard to measure on an MRI scan. The other issue is spinal cord disease. So the repeated ongoing attack of MS on the spinal cord over time can cause very slow worsening symptoms, gait, balance, bladder symptoms, typically are coming from the spinal cord. And it will just, sensory numbness, tingling in the extremities or spinal cord symptoms. And those things may be slowly worsening in someone who's had MS for a while. And typically we don't see that in the first 5 to 10 years of disease, but sometimes earlier, but usually 10 years or more into MS, we'll see people have this slowly gradual worsening. Now that's one of the things we're really hopeful for with this new class of treatment, that it may work better on that slow worsening, because it really is a problem. It's an unmet need with the tools we have in the belt right now to treat the disease, and in this bucket, disease-modifying therapies. They're just not very effective at slowing down. I mean, they do slow it down, but they're not nearly effective enough at slowing down that slow worsening aspect of the disease. So in general, we might look at escalating therapy, trying to move someone to a stronger treatment if they're slowly worsening. Certainly if they're making new lesions, if we see having relapses, those would be reasons to think that they're going to respond to a change to maybe a stronger treatment. And arguably there's not much that's stronger than Ocrevus. So soon we will have some other therapies on the horizon, these ones I'm talking about, that we're very hopeful will be as or maybe more effective than the current treatments we have. But we're really hopeful that we're going to find a treatment that will impact this gradual worsening of disease, which is really, really tough. So conversation you need to have with your neurologist about the treatment options available, and also looking a little deeper. And then there are things you can remediate the worsening with, so physical therapy, occupational therapy. Those don't fix the problem, but they help your day-to-day ride if you're having worsening symptoms.
Thank you. What can you tell us more about Kesimpta and how this works for people with SPMS?
Well, I think SPMS is a term that we're sort of phasing out a little bit because we've now gotten a little more granular with that. So we used to call secondary progressive MS and sort of lump everybody together. And there are some people who are slowly worsening and having relapses and making new lesions on the MRI. Then there are other people who are slowly worsening and they're not having relapses, and we're not seeing new discrete lesions on the MRI scan, but we might see old lesions that are very gradually enlarging, or we might see the brain over time. It takes a good 5 or more years to really see this. We might see brain atrophy, that the brain's shrinking at a faster rate than normal aging. So I think with secondary progressive MS, if there are not an indication of new lesions on the scan or relapses, then we're really not sure that a drug like Kesimpta is going to have much of an impact. Kesimpta wasn't really studied in people with that slow worsening form of disease. There were people who were worsening in the Kesimpta research trials, but they were selected into that study because they were having relapses and making new lesions on the MRI scan. So I would say this non-relapsing progressive MS or secondary progressive MS without relapses or MRI changes is a really big challenge for us. We have a few treatments a little bit further down the research pipeline, and again, we're also hopeful that this new class of drug not quite proof in the pudding just yet, but we're really hopeful that this new class of drug, the BTK inhibitors, one of those may be effective at slowing down this slow worsening. They are being looked at.
What is the neurological immunological connection? What is the neurological immunological connection?
That's easy. I don't know.
Good. Next question.
Well, but Stuart, I'm never at a loss for words. Stuart hates this part. Hates this about me. It's really very interesting. There definitely is a connection between the brain and the immune system. There is, this was studied, the drug Prozac. When it was being studied, a colleague of mine at the University of Chicago did research on this. On your white blood cells, the immune cells in your body, there are serotonin receptors. Prozac stimulates or hits the serotonin receptor. So why on earth would immune cells have serotonin receptors on them? So I don't know the answer. There is a lot of research ongoing in this area to try to sort out that connection. Is there more than we know about? Absolutely. But I couldn't give you enough detail to explain it. And quite frankly, we really don't know. As neurologists, as especially in MS, as a subspecialty, we don't know for sure. Stay tuned, though. We're going to find out. Question over here. Yes.
If your problem with the contrast that you were describing has to do with your cataracts, will that improve when you have the cataracts surgery, or should it?
Yes. So when you say contrast, sometimes that gets confusing because I was talking about contrast acuity, contrast sensitivity of visual acuity, which I believe is what you mean. Sometimes we think of contrast as the dye we give people when they get an MRI scan. Right. But I understand your question is the vision one. So contrast sensitivity, if you have cataract surgery, yes, it will improve your contrast vision. Now, if you have MS2, it may improve it, having the cataract off, but there still may be a contrast problem that's due to damage in the optic nerve. But if someone without MS and no other optic nerve problem, if they have their cataracts taken off, their contrast should return to normal. The plastic lenses aren't quite like your normal lens, but glare and other symptoms like that can be an issue. But for the most part, yes, the contrast would improve.
Yeah, you mentioned the vaccination for the Epstein-Barr virus.
Yes, ma'am.
At what age, or when does to get that?
Well, we don't currently have one. Okay, it is being developed, and this is in response to this research trial where we now can identify at-risk people by their family, essentially, and very soon we're going to have, and actually we do now a little bit, but it's not quite ready for prime time. Very soon we're going to have we'll be able to do a genetic test and identify people who may be at risk, and maybe it's more than just MS, and other autoimmune diseases too, but specific to MS, if we can do a blood test and identify someone's at risk and then vaccinate them for Epstein-Barr, the key to this, we don't really know when the disease is triggered. What we do know is people who are diagnosed with MS have had MS, immune, all that mess I showed you on the slide, all those chemical messenger cells, that's been going on in their brains without them even knowing about it for years in most people. And the initial trigger that ultimately causes or triggers MS in an individual might even happen in childhood. So I think once we can genetically identify, that may be something we screen people for in the future right when they're born, and then vaccinate them like we do for the early childhood vaccinations. That's where I think we're going with this. But we don't have the vaccination yet. It is being developed. Stay tuned.
If a patient on Mayzent developed hypertension, do they usually stay on Mayzent and take another drug for the hypertension, or do they get switched away from Mayzent and put onto another drug?
Okay, so the Mayzent belongs to a class of drug we call S1P drugs. So the S1P drugs can have an impact on blood pressure. They hit these receptors all over the body, in every tissue in the body to varying degrees. So when that develops, a change from Mayzant to a similar drug might have a similar effect. If you have an alternative to Mayzant that's not in the same class, you could try switching to a similar drug that works in the same way, but again, it might have the same impact. Some of the different S1P drugs have different selectivity for the different receptors on different tissues. Already too long an answer for Stuart, so I'll hold at that one. But you may want, you talk to your neurologist about perhaps escalating to a stronger treatment or changing to another treatment if those options aren't available or aren't desirable. And depending on what's going on with the blood pressure, that's something you have to also work with your medical doctor on too, to come up with some conclusions. In some cases, the answer would be yes, if we add a mild antihypertensive treatment to your current blood pressure regimen, or if it's something like a mild diuretic that's not going to have a lot of side effects for you. So in some cases, yes, adding an antihypertensive if the drug's working well for you and the other alternatives aren't desirable. But it should at least trigger a review of the other treatment options that are available in a different class that wouldn't have that impact on the blood pressure. Yes, hi.
Hi, yes, I have two questions. So first one is, with the BTK inhibitor drugs, are they being developed as like infusion drugs, pills? Like what type of drug medication will it be? And then my second question is, I've read articles linking articles with research saying that there may be like different bacteria, like gut, that's linking like to MS. Have you seen those research articles and have any information on that?
Yes. So the first question's, oh crap, I lost the first question. What was it again?
The method of the BTK inhibitors, will it be infusion?
Oral drugs. Sorry, I knew it was an easy answer Stuart would like. Oral. Oral once a day tablets. Okay, so that one's easy. And then, oh gosh, I only do one question at a time. So the BTK drugs, and then gut health, yes. Very interesting data on gut health. And so we're learning more and more the so-called gut microbiome, the different organisms, whether it's bacteria, fungal-like organisms that are very, very important not only for your gut to work, but they do impact your we know that gut health impacts the immune system. We have studies showing that some of these studies out of South America actually were very interesting a decade or so ago, demonstrating that if you had pinworms, a parasite, your MS was less aggressive. So that first started to tip us off of why we wanted to look at gut health. Like, why on earth would that be? Well, at any point in time in your body, 50% of these circulating immune cells, the immune cells that are causing the problem in that slide with all the immune cells in the brain, they are lining your gut. So half of the immune cells in your body at any one point in time are right there in your gut, ready to defend against foreign invaders that get in that way. So we started looking more and more about this and finding more and more that people with MS have some similar patterns in differences in the different types of organisms in their gut. It's led to some studies. We're now supplementing that. It's so-called fecal transplant. Everyone's finished eating, right? Sorry. So yes, literally a fecal transplant. So this is ongoing research in MS. It is generating very interesting results, and I think this is something we're going to be, and many people are taking probiotics, and some people are actually taking some of these supplements for their gut health, actually supplementing some of these bacteria and organisms. I think that's something we're going to add and be more and more adding to the regimen of treatments, like the Tysabri, Biosimilar, natalizumab, those types of therapies. I don't ever see that as probably being the only treatment, but I think like anything else, diet, exercise, all these other things, we can bring that to bear. Vitamin D, every little bit we can help to float somebody's MS boat, we want to do it. And gut health is a really key thing. It's tied to diet as well. If you want to, there's an old article you can look up on NPR radio about a guy talking about a fecal transplant. So, it's really hard if you want to be a fecal donor. The screening process for a fecal donor is more rigorous than giving somebody a kidney. Just think about that for a minute.
Next question. Thank you for that answer. A little crappy, but okay. All right. Let's see. Are there, we'll go to this one first. All right. So is there anything called Quantix blood test for MS?
Quantix? How's it spelled?
Quanteix blood test.
There might be, but I'm not familiar with it.
Okay.
So.
Can you tell us then about the Octave blood test?
Yeah. So I'm not familiar with the first one, but Octave is a set of biomarkers. So these are, it's a single blood test, but it measures a bunch of different proteins. These proteins, so far, they have a really tight correlation where they've studied people with MS over a period of time. People are having relapses, making new MRI changes, and they tracked the protein changes in their blood. Through this process, they've been able to identify certain proteins and patterns of how these proteins change. Some go up, some go down, some do different proteins in different spheres of whether, tell us whether the nerve cells are being damaged, tell us whether there's inflammation in the immune system, various things like that. So this is a blood test that we can do and get. Right now, Octave is deriving a score for people where they interpret the test on a 1 to 10 scale of yes, well-controlled, low inflammation, all the way up to aggressive, very, very high risk that someone's going to do very poorly and develop a lot of disability, or at least relapses and MRI changes. There's one other aspect of the Octave test that is currently being developed now that is going to take a little more time, and those are biomarkers on progressive disease. But yes, very important. And I think what we're just now starting to see arrive in MS is something called personalized medicine. I mentioned before, joking, that we're all snowflakes. Biologically we are. Our bodies are very different, intricate inner workings. So I think ultimately personalized medicine is going to be able to identify maybe from genetics, we identify that you're at greater risk of having more disability in the future. But in other words, personalizing the treatment for you, as it stands now, we study groups of people, and then we say, well, you're in this group based on our research, but we can't really say how you're going to do. In the future, we'll be able to personalize that. And I think drugs or tests like the Octave biomarkers is really the first wave of this personalized medicine in MS. Great question. Thank you.
I'm going to cycle back to the JC virus.
Uh-huh.
Is it true that once you're positive, you're always positive? And then how do you decide when to stop someone on Tysabri?
Yeah, so two questions there. So the JC virus is the virus that actually invades into the brain to cause the infection called PML, progressive multifocal leukoencephalopathy. We'll just call it PML. What we measure in your blood is antibodies against the virus. So if you're exposed to that virus, your immune system is going to keep a record of that, and you'll have circulating antibodies in your blood. Over time, what we see when someone's first exposed to a virus, the antibody levels, this is just in general, but also applies to the JC virus. The antibody levels are very high when you're fighting, initially your body's fighting that infection. JC virus actually doesn't cause disease in humans, cause any symptoms at all, unless they're immune suppressed. So your body can fight the infection, fight that virus, and you can have antibodies and never even know you were sick. You weren't sick. So measuring those antibodies, if we get a high level of antibody when someone's exposed, and then it will gradually decline over time. This is what I've seen in people who go from negative and jump really high, and then it'll trend lower. What's said, if it goes above 0.4 range on the virus test, that it probably is never going to go back all the way to 0 or negative. I actually have seen that happen. But in general, it will tend to stay elevated. Now, we also can tell, based on your second part of your question is, when would we discontinue or worry about discontinuing Tysabri? A couple scenarios. One relates to the JC virus antibody levels. If your antibody levels are above a certain level, or the level of the antibody within a lower range does imply the risk, or how much risk, the chances of you getting that infection. Then higher levels of the virus, or if the JC virus level is gradually creeping up, that's a scenario where we've seen PML develop. Doesn't mean you're going to definitely get PML if your JC virus index, as we call it, is gradually creeping up. But that's a scenario we watch for carefully, and I might be inclined to discontinue a treatment if I saw someone go either above a certain level with their index or even higher.
What is the level of the index that you're talking about?
So the JC virus index typically above 1.5. The index, we consider it being a higher risk. And that cutoff, in part by the way the research study was done, it probably does grade with higher levels, but that's kind of the cutoff of higher versus lower risk. Now, we can mitigate the risk. A recent study has shown, in fact, we were part of that trial. If you reduce the frequency of Tysabri, it's an every 4-week infusion now. If you reduce that infusion frequency to every 6 weeks, it lowers the chances of getting PML by 88%. So that's often what we'll do in someone if they've got a lower index. There are other reasons to think about discontinuing Tysabri. Probably the next most common reason I find, there's about 6% of people who develop antibodies. Their immune system will make antibodies that attack the Tysabri, and then Tysabri won't be effective. So that's another reason that we might have to discontinue Tysabri. But by far, the number one reason we have to make a change is the JC virus test. Very good question. Thank you.
So going further with that, though, as a person ages, and this is what comes up many times, of course, not saying to come off of it, but if a person is testing with low titer levels for the JC and they're on Tysabri, does that worsen with age, or are they at higher risk as they age?
Not necessarily. I think we really pin everything on the index. I get the argument, though, that as we age, our immune systems are less effective at fighting infections. But for JC virus, I think when we start thinking about aging, there are other drugs I'm more concerned about that have a broader impact on the immune system as people age. And depleting agents can be correlated with more infections and various things like that. And as we age, we're at greater risk for infections anyway, as our immune system senesces or kind of ages and calms down.
What more likely affects our walking? Is it the lesions on our more lesions on our brain or on our spine? Like, what affects our walking ability?
Good question. So and her point is basically where the lesions occur in the nervous system do determine to a large degree what kind of symptoms you're going to have. So lesions higher up in the cortex, in the thinking part of the brain, are more likely to affect cognitive function. Lesions in the brainstem, coordination, balance. So if your walking problems, if the person with MS's walking problems are more like they're staggering, and people think they're drunk, that tends to come from the base of the brain. There is a mild balance problem that comes from the spinal cord. If the problem is weakness and spasticity, that's usually coming from the spinal cord. Walking with a cane could mean you're using it for balance, or walking a cane could mean you're using it for some degree of weakness and support. So a mild balance problem, especially if it's associated with a lot of numbness and tingling and kind of sensory loss in the feet, may be coming from the spinal cord, but that kind of staggering, when you see people's arms that kind of waver, if their MS is kind of like that and their coordination is really bad, that balance problem is usually coming from the base of the brain. I'd say the majority of people with walking problems in MS, it is coming from the spinal cord. But again, it would be, now, your neurologist can tell based on your neurologic exam where those symptoms are coming from. That's kind of what we we're geeky. We sort of know how you're wired up, and we do your examination, and then we figure out where in your body is the problem. So they'd be able to tell you, we call that localization. So your neurologist can localize where your problems are coming from based on your examination and know whether it's your brainstem or your spinal cord. So it'd be a good question for your neurologist.
Thank you. Next one. Yes, no. Can you get prescription eyeglasses with a yellow tint, or are they just available over the counter? Yes.
Stuart, that's not a yes or no question. How can I answer that yes or no? Yes and yes. You can get prescription, you can get them over the counter. You can't get prescription tinted glasses over the counter, but you can get prescription glasses tinted, yellow. Your optometrist or ophthalmologist can do it for you. You can get and you can buy non-prescription. I haven't seen any readers with tints in them, but I guess you could get them.
Okay, next one. What is the status on remyelination medications?
Yes, disappointingly stuck in phase 2 research trials. We've had a lot of hopes for this remyelination. When I showed you on in the presentation the damaged nerve cells, the ones that don't die, those oligocells, if the oligocells are around, or you can convert some oligostem cells to make new oligocells, then you can remyelinate the damaged nerves, and that's exactly what these drugs, some drugs, and actually a few common things we know do promote remyelination. One of the most common things that promotes remyelination is vitamin D. There's also another, and this is not ready for prime time. This drug is available over the counter as an antihistamine. It's called clemastine, but it's in a different dose. So don't try this at home. Clemastine is not ready for you to go down to the drugstore and buy it and start taking it in large doses. Don't do that. But it is being studied as a remyelinating drug, and I'm not sure that's going to be the ultimate remyelinator, but it may give us clues to develop other treatments that are effective to help the damaged nerve cells work better. But just remember, remyelination's part of it, but if the nerve cell dies, it's gone forever. There's nothing there to remyelinate. So the key in MS is still keeping those nerve cells alive, because down the road, as we get remyelination therapies, if you lost a lot of nerve cells, there's nothing to remyelinate.
Okay. Second to last question online, and then you could go to the airport. Any studies happening on hyperbaric oxygen chambers and with MS, since they are used for TBI patients and inflammation?
You know, I'm not aware of any current hyperbaric studies ongoing with MS. This has been looked at and really quite intensively, intensive may not be quite the right word, but there have been studies specifically to see if hyperbarics could be used to treat relapses. The notion being pushing a lot of high pressure oxygen into the tissues. In general, the answer is no. Hyperbarics have kind of been disappointing. So they might turn out to be useful in concussion type injuries, but at this point, there really is not a role for it in persons with MS.
Thank you much. Last question, and this could be multi-parted as well. Is childhood trauma linked to an increase in multiple sclerosis or any other trauma, even as a young adult?
So by trauma, I would assume they're talking about physical trauma, and I think the answer is probably the same for both. I'm going to say a qualified no, only from the perspective of we haven't proven it, but it would be a pretty difficult thing to prove. Could a minor or even moderate head injury predispose to developing MS? Maybe, but we just haven't proven it. Now, emotional trauma, there is some old data on that of saying if someone has a major life-changing event, death of a spouse, loss of a job, all of those things happen at once, something like that, that emotional and even physical stress has been correlated in mostly older studies, but has been correlated with a slight increased chance of developing a relapse. So that's why, again, I'd say a qualified no.
I think that's it. We're going to wrap it up. I'm even going to come up there and shake your hand, all right? Thank you for presenting.
Thank you very much. Thank you for having me.
All right, so I'm saying goodbye. We'll see you next time online. Have a good one. Bye-bye.